Hello, everyone, and welcome to today's webinar, Turning Passion into Action, Policy Levers for Change. I'm one of your hosts for this afternoon or this morning if you're on the West Coast presentation. I'm Alex Spanko. I'm the Director of Communications for the Center for Innovation, which is the Greenhouse Project and Pioneer Network together. I'm also joined by my colleague, the incredible Anne Montgomery, who will be taking over for the second half of this presentation. So we'll hear from her in a little bit. Before we get started, just a couple of housekeeping items. Continuing education is available for today's webinar. All the information is here. There'll be a link in the chat if you're looking for nursing credits. There'll also be a survey at the end of today's presentation um, for all attendees, but there will also be some questions in there for continuing education credits that for other than nursing. So for the administrators and the dementia practitioners. If also for whatever reason you just need a certificate proving that you were here for this for other professional continuing education, you can request that as well. Here are also the education goals for today's program in accordance with our continuing education. At the end of today's presentation, you will hopefully be able to identify at least one policy strategy that might work for your organizations or within your state, and then also name one of the current top federal or state priorities related to long-term care and how it might affect your current practice. So I want to start off today by saying that the time is now. A lot of us, if you're on today's presentation, you have probably realized that we are at an inflection point. There is still a ton of, excuse me. There is a ton of anger. There is a ton of passion out there for reform in the nursing home space. Unfortunately, that has not really translated into action. So the time continues to be now. It is a little bit frustrating, as I know it is for me and a lot of you, that sort of the disaster that we saw during COVID didn't, immediately spur change. But there's a lot of momentum that happened both before, during, and after the pandemic that we're going to talk about today that will hopefully inspire you to kind of take some action in your communities, in your states, in with your federal representatives, and more. So very, very briefly, I want to go through what the greenhouse model is. I'm guessing a lot of you already know, but it is small, private living, basically reimagining the traditional institutional nursing home in a household setting, not just home, but home-like. No more than 10 to 12 elders per individual home, multiple homes on a campus, all private rooms and bathrooms, universal caregiving practice where staffing structure where workers are most of the employees are traditional CNAs, they're licensed as CNAs, but they also provide housekeeping and they cook meals fresh 3 times a day in a residential kitchen. So not food service, not eating off a tray, not a cafeteria. These are all examples of what greenhouse homes look like. I just like including these pictures so you know that where we're coming from and kind of what our vision is for a better future. This is a greenhouse community. This is one of our communities in Arkansas. So this is kind of the more traditional single family. I like including this picture because if you were flying on a plane and you saw this, you probably wouldn't think that's a nursing home, but it is a nursing home. This is also a greenhouse nursing home community. This is the Leonard Florence Center outside of Boston, where each individual floor is its own self-contained home of 10 to 12 people. And that even includes a front door with a doorbell that you have to ring once you get off the elevator. I know a lot of folks have probably been in high-rise nursing homes, when the door is open. You're kind of in the middle of everything. There's a nurse's station, there's beeping. Kind of feels like you're in a hospital. That's not the case in a greenhouse home that's built this way. You actually have to ring the doorbell and be let in. So these pictures are really to emphasize that there's urban, suburban, rural greenhouse settings. These kind of household model nursing homes can be implemented anywhere. So here are the fast facts. You'll get all of these slides at the end of today's presentation. So most of these are included just for reference because I want to get to the meat of today's presentation. Just to note there, we have more than 400 homes across 80 campuses in the United States and now Canada. Most are operated by nonprofit partners, though some are for-profit. 80% are licensed as nursing homes. The rest are assisted living, but then there are also some really unique communities that have adapted other types of care, not just elder care. So we have the Wyoming Life Resource Center in Wyoming, that they replaced a very traditional institution for adults living with intellectual and developmental disabilities with a greenhouse community. The Leonard Florence Center, which I showed you earlier, that high rise, it serves both elders and adults with complex medical conditions, including ALS and MS. And about 50% of the residents across this network are covered under Medicaid. That's obviously dependent on the site. The Arkansas example I showed you earlier, that's about 65% Medicaid. We have some that are exclusively Medicaid, including an exciting community that both Anne and I are going to talk about over the course of today's presentation. So again, we also want to emphasize that this is not a product for the affluent. This is not exclusively a private pay product. There are private pay nursing home greenhouse rooms, especially more on the assisted living side. But again, 50% of residents across their network are covered under Medicaid. And many individual greenhouse communities serve the same or similar Medicaid populations as your average traditional nursing home. So this is something that can be a Medicaid product. These are some benefits of the household model, specifically looking at our greenhouse research. Lower COVID infections and deaths, significantly reduced workforce turnover, greater occupancy, increased direct care time, better satisfaction, timelier interventions, so better outcomes, and actually reduced Medicare spending derived from fewer rehospitalizations. So there's a lot of benefits here for everyone involved, all stakeholders, right? A lot of times when you're talking about nursing home reform, obviously you're focused on residents and caregivers and their families because those are the primary stakeholders. But one of the things that we're really going to emphasize in today's presentation is that our strategy and our vision for reform is about changing the landscape so that what is good for people, what is good for residents and caregivers is also good for operators, also makes it so that we're paying for what we really want and that we're not paying for what we don't want. Very quickly, here is a staffing comparison. This is a slide just because the staffing standard for nursing homes is currently in the news, in the conversation. Greenhouse homes meet or exceed all of the new federal standards already. This is retrospective data for about 30 greenhouse communities, those that are exclusively greenhouse. So all of the CMS information is exclusively greenhouse. There are some that have both traditional and greenhouse, so separating out the data can be difficult, but these are 30 exclusive greenhouse communities, and the staffing, as you can see, exceeds all of the new federal standards. This is before the standards went into effect. So here's the policy problem as we see them. As I'm sure a lot of you know, most people don't want to move into a nursing home themselves or see a loved one in that setting, but there's little incentive for providers to change. I always like to say that if you want to do well, if you want to do good in the nursing home world, if you want to really break out of the paradigms that exist, it's very difficult. But if you want to coast on what already exists, just kind of make as much money as you can on the existing broken system, that's pretty easy. So how do we realign those incentives so that, like I mentioned earlier, what we want is what we're paying for, and what we don't want is what we're not paying for? Uh, Home and community-based services. I wanted to take this opportunity to say we love home and community-based services. A lot of times in the reform world, it's often settings are kind of seen as being pit against each other, right? Home health sees nursing homes as competitors. Nursing homes see expanded home health as a threat to their bottom line. We're not looking to have a world where it's a bunch of silos fighting it out. We want to create a world where there's a full continuum of care and where all levels of care and all types of care can be provided in many different types of settings. Skilled care can be provided in the home. Skilled care can be provided in a community that looks like a greenhouse community. It can be provided in a lot of different areas. And also remembering that not everyone aspires to aging in place at home. A lot of people do, and we want to create a continuum where that's possible for everyone, not just the people with big houses, not just the people who can afford private care aides. But we also acknowledge that a lot of people want a community as they age. If you're living in a rural area or you're living in a 6, 7 story walk up and you don't have a spouse or a partner or family, it can be very isolating to receive care exclusively in the home and not have a community of people. And one thing we learned during COVID, among the many lessons, is that isolation can be just as deadly as any virus. So this is kind of the interlocking complex problems But here's the good news. Here's the reality. We don't face a choice between the free status quo and an expensive alternative. I hate this framework. A lot of times, when we present on Greenhouse, and I'm sure Anne, whenever she presents on any number of the unique new models she's come up with and she's worked on over the years, the number one question is, well, how are we going to pay for it? That sounds expensive. But I want everyone to remember, and I want use this as a talking point if you're ever having a conversation with your policymakers, lawmakers, anyone, is that we're spending a ton of money on a current broken system. States spend billions and billions and billions of dollars, and the federal government spends billions and billions and billions of dollars on care settings that people don't want to call home. So when we're talking about shifting incentives, we're not talking about something that's not affordable. What we have is not affordable because we're paying tons of money for stuff that people don't, the services that people do not want, settings where people do not want to work, and settings that can be very dangerous and very inhumane for too many people. So how can states more effectively spend that money on high quality, empowering care? And how can we do that in a comprehensive way where we're not looking at, okay, we're going to improve nursing homes, or actually, no, we're not going to improve nursing homes. We're just going to invest solely in home health. Well, actually, no, we need to build new nursing homes. So instead of looking at it that way, how do we come up with a comprehensive plan? And so these are recommendations that we came up with. The Greenhouse Project, last year, we were contracted by the state of Maryland to basically ask the question, why aren't there greenhouse communities in the state of Maryland? What steps, this was a report done for the Department of Aging, and I want to give a big shout out to the Maryland Department of Aging and Carmel Roque, who is the secretary. She has a really powerful vision. The state of Maryland has a really powerful vision. They have the Age Friendly Maryland initiative. Their governor is really dedicated to not just looking at discrete nursing home reform or HCBS expansion, but how do we create a Maryland where people actually want to age, first of all. They're not fearing growing older, but then they also can thrive and have a great life as they get older, and not just, oh, how do we make sure that people don't end up in bad nursing homes? So these are kind of the big picture recommendations, and these are discrete recommendations, policy recommendations that all have a precedent in another state. So even though I mentioned that we did this report on behalf of the state of Maryland, the idea was to answer the question, what have other states done? How have other states made this work? And it's a question that I get all the time in my role, where if I present on the greenhouse model, on household models, on new innovative types of communities, the question is always, well, what have other states done to make this work? So I know I said Maryland, but try to remember that the whole point here is that these are lessons from states that you can apply to any state in the country. So number one is certificate of need reform. I could talk about CONs for an entire presentation, so I'll try to keep it very brief. Most states, I think it's 37 out of the 50, have some kind of certificate of need law. That means that there is a cap on the number of beds, it could be nursing home beds, hospital beds, assisted living, whatever, that can operate in the state. Functionally, what that means is that there is very little incentive for providers of traditional nursing home care to give up bed licenses, right? Because you need a license to get Medicare and Medicaid reimbursement. So that's an asset. And if you're a forward-thinking organization, you can't just enter the market. We've have organizations come up to us all the time and say, we have the land, we have a desire to build greenhouse homes, but they can't because they can't get a certificate of need. They can't get the bed licenses. And so they have to wait for an existing nursing home to close so that those bed licenses might become free again. But remember, these are also assets. They're bought and sold. The comparison I like to make is that if you're into your local food scene, you may read stories about, oh, there's a new restaurant opening in the neighborhood because someone got a new liquor license. And those liquor licenses are bought and sold on the open market. A lot of states have that. It's the exact same premise. In order for me to open a nursing home, another one in the state has to close so I can get those bed licenses. Those bed licenses are often very expensive, and we've found a disturbing trend is that mostly for-profit operators, the most well-capitalized, but maybe not the most resident focused, are the ones that can come up and buy those. So there's trends of nonprofits exiting the nursing home space, selling those bed licenses, and the only buyers are for-profits that you really probably don't want running more nursing homes. Fully repealing the certificate of need laws is very politically challenging because, like I said, these are assets to just kind of wake up one day and say, all right, We're getting rid of these assets, and we're also making it easier for competition to come in. You can imagine that the lobbies, both on the for-profit and nonprofit side, are not a fan of CON repeal. But exemptions already exist in the state of Maryland and many other states. So many states have used CON carve-outs to encourage small home development. And here are some examples of that. So in Indiana, they have what's called an exemption for a small house health facility. So any community with 50 beds or fewer, you don't need to go through the CON process. Rhode Island had a bed moratorium, which is a kind of CON, basically saying no new beds can operate in the state. We're not issuing any new ones. But they made an exception saying that if you wanted to build a greenhouse home, a home that uses the Eden alternative, which is another wonderful person-directed household model care framework, or other small house models, you can build outside of that moratorium. And one of our partner communities in Rhode Island actually used that exemption to build a greenhouse community, St. Elizabeth. Of note, that moratorium was repealed entirely in 2022, and they haven't received any new applications for homes. One of the arguments you'll hear for CON is that we need CON because we can't have the market flooded with subpar options. So they haven't had any sort of CON moratorium in Rhode Island for 2 years now, and they have not received new applications. Maryland also had already had a host of exemptions for building, excuse me, for building new nursing home infrastructure. For example, communities in areas with low quality options. I think if there were no nursing homes with more than 2 stars on the federal government's star rankings, you could build outside of the CON. You could add incremental amounts of beds. So you can add 10 beds or 10% of the bed total, whichever was lower. You could also replace an entire building with 100 beds or fewer without going through the CON process. Medicaid rate add-ons, another exciting area. Small rate increases have led to big development in states like Arkansas and Ohio. Very crucially, this is not a blanket rate increase. A lot of the discourse around nursing home reform, I like to call it funds versus fines. The industry says, just give us more money, don't ask any questions, but it'll get better. We just need more money. Advocates say, well, we don't know where that money is going in the first place. We don't think you need more money. And so the argument stalls because lawmakers are only given two diametrically opposed options. We advocate for a third path, which is provide an incentive, but only for providers that are willing to do something new with guardrails to ensure the money is spent correctly. And that last bullet point is crucial. It can be paired with bed delicensing, so states can right-size nursing home capacity while compensating providers for those bed licenses that are coming off the market. And I'll explain that a little more on this next slide here. Arkansas, about 15 years ago now, they managed to push through a $4 to $5 extra Medicaid rate add-on per day for small house nursing communities. That money came mostly from the federal match, so it did not increase state spending on Medicaid. And there are now more than 50 greenhouse homes across the state of Arkansas operated by our operating partner in the state because he was able to secure funding, secure investors to build these based on that rate increase. Ohio, just this past year, they got a $30 a day rate add-on for fully private rooms, $20 for private rooms with shared sinks and toilets. Obviously, we prefer the fully private. Crucially, their operators have to already have private rooms or relinquish the bed licenses to create private rooms. So let's say I have a 300-bed nursing home in Akron. I can't just throw up walls in each room and say, ta-da, 600 private rooms, give me the extra money. No, I would have to give up 150 beds and then operate 150 private rooms. This is really important because a lot of states are looking around and saying our nursing homes are only 70% full. They're probably not going to get full again after COVID. How can we kind of right size the capacity, acknowledging there will always be a space for communal settings? How do we do that while also getting around the fact that those are assets, there could be lawsuits and pushback? So what this additional rate does is it kind of compensates providers for taking those beds offline. It achieves that goal of right sizing, and it achieves the goal of creating private spaces for residents. And then 24 states have paid for performance or Medicaid value-based purchasing programs. Usually this is quality-based, so based on outcomes, but there are states that have started to experiment with physical transformation, culture change. Kansas is a great example of that. I'm going a little quickly because I want to make sure Anne has time to go through her framework because it's fascinating. But this is another idea is create a pilot program. If the CON reform or the Medicaid rate increase is too daunting, which it might be, what about a pilot? What about let's take three providers in our state, let's give them some incentives. It could be a grant, a tax credit, a loan. It could be a rate add-on, but only for certain providers. And let's see how it works. Let's see if we can make it work with three communities and then duplicate it around the state. You can collect data to figure out what works in what areas. You can tailor it because, states are very, I live in New York. Let's go Mets, by the way. I live in New York, but it's like five states. I live in the New York metro area. That's very different from upstate New York, which is very different from Long Island, which is very different from a lot of different parts of the state. So you can really tailor the program and kind of learn what works in what area and what doesn't. There have been federal bills on the docket, which you can see there. New York, they created a $50 million grant program that's currently underway to try to get organizations to either rebuild or build new small home infrastructure. New Jersey, they released a major task force report just this spring about sort of a COVID postmortem, and one of their big conclusions was that there should be a demonstration project to incentivize greenhouse homes. And California created a whole pilot program with its own set of new standards for small homes. And our partners at Valley Verde, which is a community in Southern California, will be the first to participate. It's a whole new oversight and regulatory framework that they came up with specifically for small house nursing homes. Streamlining the regulatory process. So I mentioned that framework. It can be very difficult because the regulations that were designed to oversee nursing homes were inherently reactionary, right? The nursing homes came first. There were tons of problems with those nursing homes, beginning from pretty much the start of federal funding, even before that. But, in the 60s and 70s, it became a federal issue with Medicare and Medicaid. The rules were kind of retroactively designed to regulate the outdated model. I always say that if you gave a bunch of space aliens the regulations for nursing homes and told them build a nursing home based on this, they would only build you someplace you don't want to live. Um, we need to reimagine what regulating nursing homes looks like. We need to figure out a way, when our partners build new small house homes, they often run into trouble because it doesn't look like a nursing home. We have a little bit more autonomy. There's an open kitchen. Residents are allowed to leave and go outside to a secure outdoor area without asking permission. These are all things that provide dignity, autonomy, really just a baseline level of respect for elders. But often they run afoul of the letter of the law, if not the spirit. So we encourage states to come up with a streamlined regulatory process so that they can, easily fix those gaps in the law and also infuse. Again, we're not talking about relaxing rules so, residents can don't have any ability to get relief in cases of abuse, neglect, and fraud. We're not trying to make it easier to skirt safety rules. What we're saying is, how do we make the rules and regulations fit with what we actually want, much like we want to change the incentive so that we're paying for what we actually want and not paying for what we don't. And then finally, visiting innovative communities. Visiting innovative communities. It's something that I really encourage everybody to do because seeing is believing. And you can speak on behalf, when you're having conversations with policy folks, you can speak on it a little bit better if you've actually seen it. So Otterbein Senior Life is a great example. They have 50 small homes across the state of Ohio. Tomei Rivertown, which is what Anne will be talking about very briefly, is an awesome community that combines assisted living homes that are set up as greenhouse homes, affordable independent living, and an on-site PACE day center for elders, all on one site. So it's a full continuum of care, all covered under Medicaid, all right in downtown Detroit at a reused, adaptive reuse community. So that is an example of something that is breaking out of these paradigms, coming up with something new, and really encouraging lawmakers to think bigger, not just thinking about how do we fix the broken nursing homes, how do we fix the broken home health system, but how do we actually build a full continuum of care where people can receive the services they need where they want it. This is a brief plug, and then I'm going to toss it over to Anne. But we're both involved with the Moving Forward Nursing Home Quality Coalition. We have a small home work group. It's like a subcommittee that I'm honored to be part of. We meet once a month where we talk about all of these issues. How do we bring this residential style of care? How do we make that the standard for communal care? So if you're at all interested in what we have to say, we talk about this once a month. Reach out to me and we can get you added to those meetings. And without further ado, I'm going to pass it along to Anne.
All right. Well, thank you, Alex. That was a splendid presentation, and good afternoon, everybody. I'm Anne Montgomery, and I'm a longtime policy analyst, researcher, advocate, proud to be an advocate with all of you. And I hope that you are feeling like this is an inflection point. I think Alex did a great kind of tour of, what's possible really at the state level mainly. And I'm going to talk for the most part about what we might be able to get the federal government to do, because a lot of this work that has been going on really for decades is ripe for taking forward at a national level. So this is a national policy initiative evaluating innovation in nursing home systems to end institutionalization that quite a few of us pretty much dreamed up. It was myself, it was CFI, the Live Oak Project, the Great Panthers NYC, Moving Forward, Eden Alternative. We sort of thought about, what can we take forward to the Department of Health and Human Services that they would pay attention to, and how can we get them to pay attention? And so that's what I'm going to be describing. It's really a four-part proposal, and I'm happy to say we're making some progress. Okay, next slide. So here is one of the sort of anchors of this basically authority at the federal level that already exists for HHS to do a far-reaching research and demonstration initiative. It's in the Affordable Care Act. It's one of the provisions I had the honor to work on when I was with the Senate Aging Committee from 2007 through 2013. It's very simple. You can see that it basically says, the Secretary of HHS is empowered, is authorized to do a national demonstration on culture change in nursing homes. There's also one actually for the use of information technology. So that's been sitting there. And here we are in 2024, since 2010, and waiting for the administration, whichever administration wants to pick this up and do something with it. They haven't yet done it, but we are now pressing them to pay attention to this provision, along with another provision in the Affordable Care Act, which created the Center for Medicare and Medicaid Innovation that basically allows CMMI, that's the acronym, to take forward the most promising models and interventions that exist, test them, evaluate them, get all the metrics in order to show what the performance is, and then, if they are successful, make them permanent as part of Medicare and Medicaid. Okay, next slide. So, as I mentioned, we have 4 tiers that are part of the Einstein, which is a great, I think, acronym, the Einstein option. And the first one, it should be very recognizable to all of you who've been doing this work for decades. It's fantastic work. It's basically culture change in nursing homes. The second is moving to a small home model or a household unit model. The third is moving to a mixed hybrid multi-payer model. And the fourth is to really focus in on the direct care workforce, which is really struggling to basically function on both the nursing home side and on the home and community-based side for multiple reasons. And we are suggesting that an investment, which you will see is a very modest and small investment financially, would be 150 million in each of these tiers for a total of 600 million. We've talked to Congress about this, and they do not think it's insane. They are pretty interested. Okay, next slide. So here's the first slide, and it really focuses in on culture change, which is many things, but maybe the crux of it is to introduce to existing staff how it is you can transform the kind of task-oriented, top-down institutional model of care where you are not necessarily thinking so much about the individuals that you're providing services for, and really turn that around to being completely person-centered so that you're asking the elders and persons with disabilities who are younger, if they're in your nursing home, your facility, what do they want? How do they want to live their lives? And what kind of training do they need, the staff, in order to make that happen? You all have done a lot of work on this. It's spectacular, and the results are really very good. So tier one at that $150 million investment level would basically flow some money, 100K, 100,000, to 500 nursing homes nationwide, and would test out all of these different parameters, these bullets, which I won't go through. I'll leave you to read them later, and see really what the results are. And I've done similar work, and many of you have done similar work when I was at Altarum, and it works very well. It would be a learning collaborative model. We would collect the information, and we would see where the cost savings are, where the workforce impact is, where the quality of life and quality of care gains really show up. And it would be in nursing homes that wanted to participate, to put their hand up, essentially. All right, next slide. So here in tier two, this is the transformation for nursing homes that are ready. And it's all about where nursing homes are and where they would like to spend their energy as to what they would apply for if the federal government put out a funding opportunity for them to do so. And in this case, it would be for those nursing homes that are ready to make that physical conversion that Alex talked a lot about. So moving to private rooms with 8 to 12 to 14 persons who live there, a different kind of staffing configuration. Could be different floors, as Alex pointed out, in a high-rise situation, each one being a household model or a small house, could be standalone, suburban style, cottage style residences. And that is a big switch that many nursing homes would like to make. And some of them are, of course, doing that in states that have figured out what those incentives really need to look like in order to incentivize providers to do it. But why don't we do it essentially at the national level? That's what this tier two would focus on. And if you read through the bullets, and by the way, we want your input, we want your feedback, we want you to send us ideas for additional bullets. In other words, if the federal government puts out a funding opportunity announcement, are these the only aspects that should be in tier two? Or should there be additional aspects that we would like to include in order to get the best possible results? So you can see in this tier that we would want to engage. CMS would want to engage the Department of Housing and Urban Development in order to tap in to the financing that they have to help build or rehab small houses and household unit models. USDA has financing, and perhaps other possibilities exist in tax credits that can be slightly tweaked and modified, like new market tax credits, in order to accelerate builds and rehabs for small house and household unit models. These are ideas that basically the time has come to make them happen as we move into a long life society where more than 20% of the population is 65 and older. All young people, most of them, can look forward to having long lives. So we really need to kind of normalize this sort of work and invest in our communities across the country. Okay, next slide. All right, so in this tier three, this is a heavier lift. This would be for nursing homes, which of course offer skilled care, that recognize that in order to provide a full continuum of care, light touch care, moderate care, and skilled care, they really need to partner with other kinds of healthcare providers. And they also need that HUD money in order to build and rehab. So what are those other providers who might be willing to partner and available to provider in our current, in order to partner? Who are they? PACE plans might be one. Fully integrated dual eligible SNPs might be a good partner for skilled care. Area agencies on aging would offer, light touch care, assisted living, which is pretty much different in every state. Those folks might be interested in partnering to create that continuum of care model and normalize LTSS at the community level. Each community would really have a different array of assets that they would want to bring to the table. No two communities are exactly alike. So the way that we envision that this might work is that essentially you'd have some community organizing, You'd have meetings around conference tables with providers, with lenders, with financial and philanthropic folks, very much like the Tomei Rivertown project, which I'll talk more about in a minute, and which, by the way, is part of the CFI conference coming up in November. There's a site visit to Tomei Rivertown, which is in Detroit, Michigan, and it's a really spectacular example of this continuum of care. All right, next slide. So Tier 4 is really about the workforce. The workforce for not only nursing homes, but for home and community-based service providers is not in good shape. We have massive shortages. And as the population grows, I'm a late boomer, and the need grows for these services to be brought to people, hopefully where they are living, we are not in a good position to meet the needs. So how can we change that? Again, we envision a federal role would really be helpful. As you can see, we have statistics from DOL, from the Bureau of Labor Statistics, that forecast we need well over 1 million additional direct care professionals in only a few years to suddenly appear. That's not happening. We're actually moving in the wrong direction. And we've lost a lot of workers. And that, of course, was because of COVID, but there are many other reasons. The sector is not well organized, it's not well compensated. And what is it that we could do to invest in the direct care workforce to begin to empower it and to improve it and to scale it? Well, one thing we could do is we could put online a series of trainings that are based in core competencies, which have been outlined by numerous providers, whether that's nursing home providers or PHI, by unions, by all kinds of nursing home associations, by researchers. What are the serious, core skills that direct care workers in all settings, across all LTSS settings, really need? And how can we basically array them in a curriculum that is free and that is online and available to people to take whenever they wish? So we've been talking with all kinds of organizations, including the Eden Alternative, including CFI, including the National Association of Healthcare Assistants, AARP, many, to basically see, do you think this is possible to put together such a free online curriculum? And we've gotten some pretty good response. And we think that we may be able to go forth and test out, how to begin to put together a universal curriculum for direct care workers, or direct care professionals, as we like to call them, and test it out in 2 states. So we're working hard on that. In addition to those trainings, of course, you would want a marketing campaign. And we think, again, the federal government should step in and put some money and some thought into how to do that, do the recruitment, provide the free training, and then work very closely with states and employers to remove the barriers that keep people from being able to move from job to job. Let's say you want to move from a nursing home to a home care agency. It may or may not be easy. You may have to go back and get additional training, additional certifications. Often that is left to the individual to pay for. We can make it a lot easier for people, and we can also basically raise them up in terms of taking the best job in the best setting and working with various populations, older adults, younger adults with physical disabilities, folks with ID, DD, and so on. So next slide, that's basically the Einstein option as we've organized it. And as you can see, that $600 million total investment, 150 in each of the 4 tiers, is a very tiny investment, very modest. And the arrow shows you just how small it is compared to what we actually spend. And here it's a 3-year figure on long-term care today. By payer, it's a massive amount of money. It's $675 billion. And we are not getting the value that we really need out of that spending. So how about investing in the fact that we're going to have so many more older people and younger people with disabilities living long lives? So how about we figure out an LTSS system that is made up of the programs that we already have, that functions a lot better, and that people really want? Next slide. So here are some of the players that are really working hard on this, and there are many others, and we'd love to include you in our growing club. Pioneer Network, you can see, of course, and the Eden Alternative Greenhouse Project, Gray Panthers, Live Oak Project, Action Pact, Calamos Communities. That's Bill Thomas's latest generational vision of how to live in a community that has all the supportive services that you need. And there's the Tomei Rivertown project, which is in Detroit, and the pioneering work that they're doing. Next slide. So we'll talk a little bit about that Tomei Rivertown project. It's fascinating. Actually, CFI had a workshop maybe a year and a half ago, and I went to that. A colleague of mine, Joe Angelelli, other colleagues went, and we took a tour. We saw the whole thing, and it's incredibly impressive. You can see here how many seniors it's serving. It was essentially birthed as an economic development project in a very, very poor part of Detroit, along the Detroit River across from Canada, where really nothing was going on. It had been a pharmaceutical company at one point that was on that land. They had left years before, and it was really not used for anything. And along came Presbyterian Villages of Michigan, which is a progressive faith-based philanthropic organization. They've done tons of work in the housing arena, and they said, we can really turn this area around. Give us a shot at it. They started raising money. They wanted to build it for low-income elders, and that's exactly what they did. So they built apartments with HUD, Housing and Urban Development funding from the 202 program and other housing monies at the federal and state level. They rehabbed some of the old buildings, which are pretty spectacular once they've been rehabbed. And they created independent living. They created assisted living, and they created skilled care. The skilled care is really offered by the PACE program. The greenhouses that are part of the Tomei Rivertown initiative are licensed as homes for the aged in Michigan, which is Michigan's essential equivalent of assisted living. They are on their way to building a community cafe. I don't think that's done yet. They have the most beautiful rooftop garden I've seen in a while. They want to add middle market rate apartments, as you can see, and they have done a splendid job of really revitalizing that area, and it's a huge success. In the process, they've created all kinds of jobs for healthcare workers and others who are working in Tomei Rivertown. And Tomei Rivertown, by definition, is sustainable because the funding from those healthcare programs from HUD is not going anywhere. It's going to continue. So it has a ripple effect of growing economic impact and all kinds of potential to basically expand out with, for example, the middle market housing that they want to build. And they are also taking it elsewhere in Michigan in 4 other communities. I know one of them is Flint, Michigan, which is a very distressed part of Michigan. Another is Pontiac, and there are 2 others. So we're going to be studying that. That would be Alex, myself, Susan Ryan, Joe Angelelli. We're going to be doing a big case study on Tomei Rivertown and feeding that forward to the federal government and to anybody who's interested. All right, next slide. Here is another example of the kind of creativity and innovation that is really changing lives, changing minds, changing financing. And this is in Georgia. And Deke Kekto is the person who really made it happen, and he's a pretty spectacular guy. I have not yet been to this particular project, but I know it is really worth visiting. And AG Roads is also dedicated very much to low-income housing. And what they did was they took an existing nursing home, very institutional, long hallways, the usual, and they rethought it. They reimagined it physically and in terms of the training, in terms of staff deployment. And they made shared spaces. They made places where you can hang out. They basically changed the menu for the kitchens. They made it much, much easier to get inside and outside. They converted to private rooms, and they created much more in the way of physical activity, space, exercise, and so on. And I look forward to visiting it, but this is not so much the small house model, but the household unit model. And that's what Alex was referring to earlier. It works, and we need to do a lot more of it. And the federal government really should encourage it. Okay, next slide. All right, so this is a slide that basically is encouraging, I think, because it shows that there's a great deal of interest in what we all recognize as long-term services and supports, which has been, the stepchild of the healthcare system for a long time, but which is rising in salience and importance as society ages. And social determinants of health are now on everybody's lips. And those are the things that LTSS really addresses most. Quality of life. Yes, quality of care is always going to be fundamentally important, but quality of life is really where social determinants of health are: the housing, the activities, the nutrition, all of the things that the medical system does not particularly address. Is the focus really now of some serious research, some serious energy, and this is an example of it. This is the White House publication in November 2023, and it's basically feeding into the work that we're talking about here today. Next slide. All right, so this is an example, again, of the kind of thinking that's going on. This is where people are sitting down. In this case, it's Duke University, but there are many others who are sitting down, including ourselves, as part of that Tomei Rivertown case study analysis I mentioned, where you're looking at different programs that usually operate in silos that don't have anything to do with one another particularly. And rather than just leaving them as is and trying to fit everybody into one niche or another, how about combining them? How about making them into a hybrid model, into a multi-payer system? And this is the kind of thinking that goes into that. And that is exactly what the Tomei Rivertown initiative really begins to lay out on the ground. Here's how it's doable. And now we have to figure out, okay, how are we going to replicate this? How are we going to scale it? What are the quality of life parameters and metrics? What are the quality of care? What are the workforce metrics that we need to see to recognize what a high-performing multi-payer system really looks like? What about the financial metrics? What kind of return on investment? What kind of bending of the cost growth curve should we expect to see? What essentially do we want out of our investment, our federal and our state funding investment in our financial metrics? And what kind of governance and operational framework do we want to see? Don't we want to see it? I think so. The community play a major role in deciding what are those multi-payer systems, what do they look like, and how do they function? We do want healthcare providers, of course, to be part of that. And other payers can be part of that. But it really ought to be a conversation around the table where there's shared governance. So all of that work, all of those metrics, standards, parameters have to be built, have to be spec'd out. And that's why we're eager to do the case study and then moving to the national initiative that we call the Einstein option. All right, next slide. Here is an interesting slide, I think. This is a new agency that was created in the 2022 Omnibus Appropriations Bill. It's called the Advanced Research Projects Agency for Health, and it's kind of basically modeled on a longstanding in-house, think tank research agency for the Department of Defense called DARPA. And this ARPA-H is basically making money available to accelerate measurement and metrics and to really improve the science around how we can create the highest highest possible functioning systems. So I haven't yet rung up ARPA-H, but I can assure you that we will be doing that. And the point is that there's federal dollars now to create the kinds of systems, research, and metric measurement that we need for the kinds of hybrid systems that we know we need to create in the future. All right, next. And again, this is, I hope, encouraging to you. This is all federal activity, so there's an awful lot going on. So here, in this case, it was led by the Administration for Community Living, which is a very small agency within HHS, small and mighty. And they have put out a strategic framework for National Plan on Aging. The National Plan on Aging is in the works. It's not yet out. They want input. I'm sure it's not too late if you wanted to offer input. I already have. What should we really be looking for as we try to create these livable communities where LTSS on a continuum of care is normalized, where it's just part of everything? So I hope that you will take the time to look this up. It's a good piece of work. It's a good beginning. I think it needs to be expanded out. But we may have a White House Conference on Aging in 2025, for example, and this could be, one of the anchor pieces that goes into that national plan and that White House Conference on Aging. So there's a lot that, we have basically at hand. And it's kind of like picking up the pieces of a puzzle. That's how I think of it, and rearranging them and making a new and better picture for a longevity society, because that's really where we are. We're tipping into the point where we're going to have lots and lots of older people, not only as the boomers finish aging into Medicare, but on an ongoing basis. And if that's the case, and it is the case, and we have fewer 18 to 64-year-olds, fewer children than we have historically, it's time to make those investments in a long life. And I think that's it. Next slide. I think we're probably to questions. Yes. Okay. Over to you. We want to hear from you. Thank you.
Yes, we are. And that was great. Thank you. I think you can all tell that you and I could talk about this for hours as we have, not on webinars, but hopefully this was helpful and we can answer some questions with our last couple minutes here. I do see a question here about CMS. What does CMS feel about greenhouse homes and others? Have we had conversations? We actually have a letter going all the way back to 2007 from CMS. I don't even know who the administrator was at that time. Admittedly, it was a little bit before my time in the industry. I guess I was still in high school, but so I don't remember who it was. But the administrator at that time sent a letter basically saying there's nothing in the greenhouse model that is in opposition to any of the current federal standards or the then current and now standards regarding nursing homes. So there is no real issue with CMS. I'm not sure if there have been specific conversations about, evaluating the SOM or specific, pieces of regulatory language. I just know that we're also we have a weekly or a monthly conversation with folks from CMS, including Evan Schulman, who runs their nursing home division. So we are in a constant dialogue with them. They like what we have to do, but they really don't see their role as one. And I don't think I'm telling tales out of school here, but they don't really see their role as encouraging new models. That they are still very much in that mindset of, we're about oversight. They like new models, but they're not really in a position to kind of talk about creating those incentives. CMMI, meanwhile, as Anne mentioned, I think there is, that is really the wheelhouse for CMMI. And I don't know if you want to go into any sort of progress we've had with them about Greenhouse or Einstein or anything.
I think it's fair to say that CMMI is quite interested. They haven't done anything on LTSS financing. How can we rearrange the pieces of the puzzle that we have in order to create, a better LTSS financing system? But they are willing to listen. They are willing to engage. And that is most encouraging. So we want to go talk to them, I don't know, every month or every couple of months, check in because they have given us a lot of encouragement. Over at the Division of Nursing Homes, which Alex was referencing, there has been interest in the past, more interest, I would say, back in 2007. And I think it was actually Carrie Weems for a while was the acting administrator. And there was interest, and there was a good bit of rewriting of the survey and state operations manual to accommodate much of the culture change practices that were basically being used at the time. But that work kind of fell off after a while. And so it would be good to go back and really remind mainstream CMS, and the Division of Nursing Homes and other parts of CMS that they did do a bunch of work, a decade or 15 years ago, and that they could pick it up again. So there are various, ways that we can engage them, and we would love your help in doing so.
Yeah, and I would say, and to further address that question about, the regulations, the states, that tends to be where we get the most pushback, and it's multifaceted. I mean, every state obviously has its own uh, agencies that oversee nursing homes, often multiple. The one of the big pieces of feedback we got from the Maryland report was, wow, it's great that the Department of Aging is into this, but there's all these other, there's all these other departments that we have to get on board that maybe don't see things the same way. And so it is a constant, and again, it's not to say that it's not possible. We have greenhouse homes in more than 35 states. We have worked with those. It's just, I would say what we're trying to do is get to a point where it's not so much effort, where it isn't this sort of individual education effort. Oftentimes, when we go in and work with providers for a new development, it's educating individual surveyors. It's educating individual people in individual departments, and that surveyor education is ongoing. We field requests all the time. Part of what we do at the national organization is work with our provider partners to have conversations when there's a new surveyor or there's a new surveyor supervisor, and suddenly, there's much as turnover makes it difficult to change culture within an individual home, turnover and staffing shortages within survey agencies and other oversight agencies make it difficult to kind of have that created mindset of culture. And so, you may have some surveyors, some oversight people who really get it, and then they retire or they leave. And then you have new people who are a little bit more by the book. So it tends to be very state by state, person to person. Our goal here is to create frameworks so that they're not working based on individual conversations. The California example is a good one. They actually sat down and they said, we have this whole set of regulations. We wrote it in conjunction. We contributed. There were a lot of different organizations that contributed, and they created that regulatory framework. What they didn't include was any sort of funding incentive. So it's taken a long time. I think they developed this, I don't know, I think 2012, 2013. So we're talking, a decade ago. And just now, first of all, they have finally approved, it's been a lot of bureaucracy. They finally approved one of our operating partners in Southern California to start building and running a community under this new framework. But it took, fundraising on their part. It's a private organization. It's a nonprofit organization. So it took fundraising and budgeting on their part to get it there. There was no funding. You need both. You need that regulatory framework, and you also need the funding mechanism in order to get there. But again, not talking about open-ended, just give more money to the nursing home sector and forget it. It's about targeted rate increases, targeted funds, plus guardrails. I neglected to mention it, but some of those federal bills that were introduced had some pretty strict requirements for organizations. Had they been passed, which it was a long shot because we're talking about getting billions through Congress. But some of these bills, they would have required extra surveys to make sure that you're still complying, making sure that one of them said you had to operate the homes as a greenhouse for 20 years in order to receive the funding, which I don't think would have been popular and maybe might have been a little impractical. I get the mindset behind it, maybe not so much the implementation, just because I don't think anyone thinks about what they're going to be doing in 20 years. I know I don't. So I think that could be a challenge. But anyway, my point is that you need a mixture of funding and oversight. I wanted to, let's see, am I sharing let me just share my screen here so we are reaching the end of our time. I did see the question about CON exemptions in Alabama. I am not sure off the top of my head, but if I hear anything, Amanda, I know we've talked before, I can get that to you if I hear anything. Let me just share my screen. We have a couple of housekeeping things. If you liked this, we have another really cool webinar coming up on Thursday, October 24th. It's called Community Innovations. It's about a unique dementia care community that was created by two people with a really personal stake in creating better dementia environments for loved ones. It's fascinating. It's free. Thursday, October 24th at 2 p.m. You can go to the website, and I know Janet is also putting a registration link in the chat if you're interested in that. That is part of our conference preview series. And Anne, thank you. Before I even had a chance to plug it, you got me. We have the Center for Innovation Conference Pioneer Network and Greenhouse are coming together yet again in Grand Rapids, Michigan, November 11th to the 13th to talk all about this stuff, specifically the policy roundtable discussion. If you like what we had, we're going to have another conversation, me and some special guests that we can't announce yet, but there are going to be some movers and shakers in the policy realm. There's going to be tons of great sessions and information. And if you're interested in registering, there'll be a link in the slides that I send out. You could click right there. And I know Janet is also putting a link in the chat. So please take a look. Tickets are still available. We would love to see you in Michigan coming up in just about a month. To answer the question that just came in, yes, you are going to get a copy of the slides and a full recording of today's presentation. And we really encourage all of you to spread it far and wide. It's free. We want as many people as possible to see this. So please share. Also, please take a look in the chat. There's going to be a survey will pop up at the end of the presentation. There's just a couple questions. If you can answer them, that would be great. There's only 2 questions. It helps us with some of our funding to help keep these presentations free and available to everybody. So please just answer the questions. We're not asking for money or anything. It just helps us with our reporting. And then again, if you need CEUs, credits, and things like that, all the information is in the chat. We are at the top of the hour, so thank you so much, everybody, for joining, and thank you so much for presenting with me. And we hope to see you again soon on an upcoming Greenhouse and Pioneer Network webinar. Take care, everybody.
Thank you.